Awesome. So, good morning and good evening, everyone. We have today Professor Andrew Ching, who is a noted economist from the Johns Hopkins Carey Business School. Today, he would talk about revisiting the zero-price effect hypothesis, evidence from consumer drug choices in Sweden. This is co-authored work with David Granlund and David Sundstorm from Umeå University. We have his co-authors who have also joined us today. Thank you, everyone, and over to you, Andrew.
Hey, thank you, Chirantan, for having me. And so it's my pleasure to present this work. Let's get right into it. So what is this zero price effect? I wanted to spend the first part of the talk on introducing this idea because this may not be familiar to everybody, every economist. This is effect identified by consumer psychologists. And I'm going to present this in terms of kind of a linear utility model, going back to the fundamental principle of choice. So let's review this a little bit, kind of like intermediate micro. So under what conditions people would choose a product, choose an alternative or product Y over X, right? Suppose to just for simplicity, we only have two products, right? Or we can easily generalize to N products. And now a person would choose Y over X or other alternatives, even only if the net utility that the person receives is the highest when he or she chooses Y, right? So if we think of a VY as the benefits of consuming Y minus the price that you have to pay, subtract the price, right? That's the net benefit you can get from choosing Y. It has to be higher than the net benefit of choosing X in order to for people to choose Y. Okay, and so now we keep things simple and assume linear utilities are relatively separable in terms of price. Think of this as a local approximation, and usually in a local, a very local way, where linear approximations is good enough as a first order approximation. And now, what happens if we just lower the price by the same amount for both products? Well, we should expect that if we lower the price by the same amount, nothing will change because what happens is the difference of the utility matter, the difference of the benefits matter. Right? So if we lower the price by the same amount for both products, for all products, we should expect that locally, okay, nothing should change. And if we lower the price by px, okay, then what you will see is that the price of x will become zero, right? So that's what we have here. And this is what sometimes we see if for some reasons we see preference reversal. That is, when the price of x dropped to zero and the price of y reduced by px, okay? And we suddenly see that people change their preferences by choosing x instead of y. Well, then it tells us there's something special about the zero price, right? So mathematically, it will be represented by this kappa, okay? So that's what we mean by zero price effect. If somehow a product, when it's presented at the zero price, somehow you see people just jump on it, then it is a kind of really strange phenomenon that economic theory, strictly speaking, cannot explain. And this consumer psychologist brand this as zero price effect. So this is started by Champagne, Early, and Mazer. Actually, it should be, I think, I'm not, yeah. In terms of the order of the names, I kind of think that Mazer might be actually the last author. What I understand is that the research is actually started by Champagne and Early first, Mazer joined later. And Mazer actually was my colleague at the U of Toronto. She's now at BU. And so they run this experiment to check whether that would happen. So in this experiment, they use the subjects of MIT students, and they look at people choose chocolate, Hershey's versus Ferrero. And as you know, Hershey is kind of a cheaper brand, and Ferrero is the more expensive brand. And they start off with the price of Hershey is like 1 cent, and the price of Ferrero is 26 cents per piece. And what you see is that they compare 3 scenarios. One is this, another one is Hershey is 0 price, and Ferrero lower the price by 25 cents. But notice that the difference of the price remains unchanged. Okay, that means the net utility differences between these two products should remain unchanged, assuming that linear utility models applies. And when you look at Hershey versus Ferrero, if we increase the price a little bit, we should also expect that nothing will change in terms of the choice share, right? But when you look at the results, it's very surprising. What you see is that for these two conditions, when the price for both products are positive, okay, what you see is that, hey, nothing too starkly different. But when you see the price of Hershey drop to 0, okay, all of a sudden the market share, the choice share for Hershey jumped from 40 or 45% to 90%. Now that's really, really big in terms of the effect. And so this research has led to more subsequent researchers to look at this effect. So here we just highlight a few studies. So Hossein and Sani further developed, fine-tune their theory and argue that depending on how hedonic the product is, how utilitarian the product is, this effect we might expect it to be different. They think that if the products are more utilitarian, then the zero-price effect may be weaker. And the theory basically is your mindset is more motivated by the utility, the physical utility that's generated by these products, not so much emotionally driven. And then the zero-price effect will also be weaker. There are other research that look at that zero-price effect, and I won't say too much about that, except that Holy, which is kind of related to our research because they also look at the pharmaceutical products, and they look at the zero-price effect in the field data for statins, and they also found that something is happening there. And now, what we're going to do is we're going to revisit this hypothesis. The reasons why we do that is, partly because all this research are done in a lab setting. Vast majority of research in consumer psychology and in the zero-price effect are done in the lab setting. And the number of subjects that they use is small. And then a lot of the usual caveats of lab research would apply. There's always a question of how strong these results are, even though it's in the lab. Would that be, are we comfortable with extrapolating it to the real world? So when we started this project, I actually started it thanks to David Grannon, my co-author, who contacted me, and David has access to this really rich data set in Sweden, and we were talking about brainstorming ideas how to take advantage of this data set, and then as I learned more about the institutional details, it strikes me that the structure of the Sweden's market, the institutional settings, is really provide us with an opportunity to test this zero-price effect. And so let me explain to you why. Okay, so in just a few minutes. And so what we're going to do is we will be using this Swedish market, a field data, large data set, and a real world setting And this setting is going to present us with a quasi-experimental setup where we will see that people, when they spend enough on the prescription drugs, this plan provided by the Swedish government will essentially, when they pass certain cutoff, it will trigger these zero price situations for the consumers if they choose the cheapest products. So we will have situations where people at the neighborhood of that cutoff of how much they spend on prescription drugs, before the epsilon, before they come to that cutoff, they are paying positive price for the cheapest products. But once they spend beyond the cutoff, and then the cheapest product becomes zero price. Okay, and that gives us a really, really nice setting to test whether we will suddenly see more people choose the cheapest product once it becomes zero price. Okay, so that's what we're going to do. And the design really is a very nice setup that we can apply regression discontinuity. And we also have some demographic characteristic that we can control. Now, like all our natural experiments research, there are going to be some caveats, and I will talk about that at the end. So this is, as far as we know, is one of the first, it's probably the first study that use this kind of regression discontinuity quasi-experimental design to study zero price effect using field data. And so we'll see, we're really curious to see whether the zero price effect survives in these settings. Okay. Now there are reasons, I think there are, both sides of stories that may conjecture that this zero price effect should be there or not. I mentioned that paper by Hong-Sen and Sani. They argue that for products that are more hedonic, we expect to see bigger zero price effect. For products that are more utilitarian, we expect to see less zero price effect, right? Products that are less emotionally driven. And in the pharmaceutical case, in the prescription drug case, it's not quite clear to us whether the product is, entirely utilitarian or hedonic. Yes, on the one hand, this is products, drugs that will give us the benefit of reducing symptoms. So in that sense, very utilitarian. On the other hand, we also know that for drugs, placebo effect is there, right? People in the clinical environments, even you tell them that you give them pseudo pills, you tell them that you might be taking a drug in the clinical environments, in the clinical trials, those people who take a placebo will actually feel better. And there also this brand effect versus generic effect. I think that could also lead to some sort of placebo effect. And then, so it's really unclear whether we should expect to see zero price effect in this setting. So we will check it. And I want to give you a preliminary, I'm going to give you an overview of the findings before I get into the details of the analysis. So what we found is a very small zero price effect in our full sample. Okay. And our full sample basically includes everybody in our data set, all the drugs that we have. Now there's a catch. The full sample is subject to state dependence. So what is state dependence? You can think of it as, roughly speaking, kind of like hyperpersistence behavior, right? So if some patients have been using a particular drug in the past, they may be for some reason reluctant to switch to another alternative, even though they are bioequivalent and they're cheaper. Some patients just get used to take this particular pill with this particular shape and this particular color, and they're reluctant to change. A lot of elderly people taking like 10 or 15 pills a day, and just taking the same shape, color of the pill help them, make it easier for them to remember. That's the drug that they need to take once a day or twice a day. So if you change the another alternative, sometimes it can create some confusions for them. So there are stories like that. And so this state dependence effect can mask the zero-price effect, right? So it does not necessarily mean the zero-price effect is not there. And so if you think of the zero-price effect, the kappa that I presented earlier, it could still be there, but then there's another state dependence effect that is not presented in my equations earlier. And if it's there, then overall effect, if the state dependence effect is big, it may mask the zero-price effect. But the kappa may still be there, may still be strong if you just look at kappa alone. So how do we address that? So to alleviate this concern, we're going to investigate a smaller sample. We're going to try to identify a set of patients that are new or new diagnosis. Okay, and it becomes a much smaller sample, but it's still big relative to the lab setting. It's much bigger than lab settings, the data set. And there we actually see much stronger zero-price effect. Okay, so that's very interesting. In fact, what we see is that 65% of patients switch to the cheapest alternative among these new diagnosis patients. Okay, so I will tell you the cache here. I will show it to you very quickly. And as you can imagine, for the cheapest products, a lot of people want to buy the cheapest products. And I will show you that it is true that majority of the people actually buy the cheapest product, even though they're not zero price. But what's interesting is that when you just focus on the new patients, among the set of people who was choosing the non-zero price, not the cheapest products, okay, once you cross the threshold that they face a zero price, okay, wow, more than about 65% of those people, okay, switch to the cheapest alternative when they see that cheapest alternative becomes zero price. So that's pretty, if you view the results in that way, it's pretty impressive.
Andrew,
yes.
One quick question. So do you want to take questions now, or do you want to take questions at the end?
Oh, you can shoot questions. Yeah, I think that will be, I'll take questions along the way.
Okay, so I have actually 3 students of mine joining in from various places in India.
Yes.
One of them is Avik, who is a doctor at the All India Institute of Medical Sciences, and
yes.
he may have a question. I'll just unmute him to talk and ask him his question.
Sure.
Avik, you want to go ahead and ask your question?
Yeah, sure, sir. Thank you, sir. Hi, Professor Ching. I'm Dr. Avik. I'm a resident doctor in IIMS in India. Am I audible, sir?
Yes.
Yes, I can hear you.
Yeah. So, like I was just wondering whether the zero price effect has got any relation with willingness to pay, number one, and price elasticity of demand. So, like, is it so like for a drug with a higher willingness to pay, like an anti-cancer drug, if it suddenly becomes zero price, we won't prefer it because we would be suspicious of its quality and efficacy, both safety and efficacy, and also for a drug like insulin, which has got a very high price inelasticity of demand. So, if suddenly the price becomes zero, again, is it so that we don't prefer a zero price product as compared to a higher price product? So is there any relation between the two?
So I'll try to answer the first question first. I think the first question is whether when the price becomes zero, whether it will trigger people's suspicions about the quality. Is that the question?
Yes, sir. Almost.
Yes.
Yes, sir.
Okay. Now, in general, it might be, but I will present the institutional setting. I think when you see the setting, you will see that it probably does not apply because we are not looking at the price set by the firms, set by the retailers. We are looking at the out-of-pocket price because of the insurance. Okay. So the retail price can still be high. I mean, even it's the cheapest products. Cheapest just in the sense that within the same exchange group, within the set of drugs that are bioequivalent, that particular product is the lowest price. Okay, and I don't mean it's cheap, but it is lowest price. And when it's the lowest price, then the government will, after a patient has spent certain amount of out-of-pocket expenses, then the government will pick up the whole bill. Okay, so in that sense, I don't think the patients will draw inference that this product is lower quality. At least not from the scenario that when it becomes the lowest price to be zero price. Okay, and because the firms actually is not like lower the price in order to make it become zero. And the second question is, can you remind me what the second question is?
Relation to inelasticity of demand.
So
the insulin example.
Yeah, so I think the example I showed earlier is the regression discontinuity design is going to try to address that because we're just changing the price by really, really tiny, right? Theoretically, we don't expect that in that neighborhood of the cutoff, when you're so close to that neighborhood, you don't expect just lowering the price from 1 cent to 0, just like the chocolate example. You don't expect, if the demand is continuous, then theoretically, the change of demand should be continuous, and it should be just, when you change the price by epsilon, the demand should also change by, epsilon. But when you see the demand, suddenly there's a discontinuity jump. That's where we say we detect the zero price effect. And so the standard, continuous demand elasticity of, when you try to measure the elasticity of demand in that way, it is something that cannot explain the zero price effect, and that's or the zero price phenomenon. Then that's where we declare that there is some kind of effects there. Okay.
And Andrew, I had a related question. I don't know about the Swedish setting, so feel free to defer this if you're coming to this in the subsequent slides. Isn't it true that consumers or patients are not choosing drugs, but physicians are choosing it for them? And in your time period of the sample, were there changes in this decision-making power that was resident with physicians?
Yeah. So I'll try to answer that, and David, feel free to jump in if
Yeah.
David. I don't know whether David is here now. I know
Yeah, he's
I
there.
know that he has to step out at some point. So the way I understand the way it works in Sweden is, yes, the physicians will write the prescriptions, but when you get to the pharmacy is obligated to tell the patients that which alternative is the lowest price.
I see.
And then the patients will then choose, right? Because they need to know, hey, if it's the lowest price, I pay this amount. And if it's not the lowest price, the government, you will be responsible to pay the price difference on top of whatever the copay that you pay for the lowest price products. Okay, so they have to be informed about that, the patients. Yeah, and then it's the patient's decisions which one they want to take.
Okay, all right.
Yeah.
You can go ahead.
Yeah. Okay, so now here's the interesting thing I wanted to explain to you how it works. So two things that really play a role. One is what we call the good of the month. Another one is the universal pharmaceutical benefits scheme that Sweden has. So I will talk about the good of the month first. So we have already talked about these ideas that the products that is cheapest or the lowest price will receive better coverage from this pharmaceutical benefits scheme. And so how do they determine which product is the lowest, right? And so when we say lowest, that's going to be a comparison group. And this comparison group is what they call exchange group. And these are the groups of drugs that are bioequivalent, not only in terms of the active substance, but also in terms of the form of administration, the strength, and the package size as well. Okay. And so, for example, simvastatin, and anti-cholesterol drugs. And in order to be in the same exchange group, you have to have, need to be a pill, 20 milligram dose, and the packet size needs to be like 100 pills, right? So you would look at the market, and you might be able to see like 10 products that fit these 4 criteria to be exactly the same. Then they are in the same exchange group. And what happened is, if you're in the exchange group, then the government every month will ask you to submit a bid about the price that you want to charge for your products 2 months later. Okay, and then they're going to use this data to determine which products will be the good of the month 2 months later. Okay, and so now interestingly, the good of the month is not always the same. It actually changes from time to time. And now we are not addressing why that's the case in this paper. I know David and he's working with some other colleagues who is addressing these issues. But what we're going to do is we're going to take this as given. There's some randomness about which products becomes good of the month. Okay, and so to give us some exogenous variations there, and we're going to take advantage of that. And so now what happens if you are the good of the month, right? So let's talk about the prescription benefit settings. So if consumers, the benefit coverage for prescription drug is work as a tier. Okay? Depending on how much you have spent already out of the pocket expenses on prescription drugs during that year, during the calendar year. So if you have spent less than, roughly speaking, it changes a little bit, so but that's not important. But roughly speaking, if you spend less than 1,100 Swedish krona, okay, then you have to pay 100%. But once you cross this 1,100 threshold, if it's between 1,100 and 2,100, then you only pay 50% if you choose the cheapest product, okay, within the exchange group. Now, if it is 2,000 to 3,900, then you pay 25% for the cheapest product. And 3,900 to 5,400, then you pay 10%. And if you go beyond 5,400, then you pay 0 pounds for the cheapest product. Now, what if you don't choose the cheapest product? Okay, so for example, there are 2 products belong to the same exchange group, Y and X, and PY is 100 and PX is 110. Okay, so what happened is you will need to pay, if you choose X, then you will pay, for example, if you are in the second tier, okay, you will pay 50% of the lowest price, okay, products, plus the price difference of these 2 products. That would be 10. That's how much you would need to pay. Okay? So now, as you can see, this setting basically is it replicates Champagne's lab experiment setting really nicely, because as you move from tier to tier, the difference in price actually remains unchanged for these 2 products, and actually for all products, relative to the cheapest one. And then you have a setting that is from the 4th bracket to the 5th bracket. Okay, the 4th bracket is your out-of-pocket price in this example is like 10 Swedish krona, and it reduced to 0. Okay, now you might wonder, hey, this is 10 Swedish krona, but in that chocolate example, we're reducing price from 1 cent to 0, right? 1 cent is really close to, it's like epsilon away from 0. Is 10 Swedish krona, that close to 0? Yes, because if this is Swedish krona, and we convert to US dollars, divided by, roughly divided by 8 or 9, and that's like $1. And now $1 is for 90 days supply. And so if you really convert it to daily cost, that's very, very low and very close to zero. So now, of course, it's still not like 1 cent away from zero, but it's really, I think, as close as you can get in a real world setting. So this is how we're going to take advantage of this. We're going to focus on the bracket 4 and 5, right? We look at this neighborhood. And we're going to use regression discontinuity design and use the accumulated expenditures as the forcing variable in our regressions analysis.
Andrew, there's a question, if this is the right time to ask it.
Yes, please.
So Gopi Krishna Panikar, who is a former MBA student of ours and also very passionate about pharmaceutical economics, he was in my elective also, I remember, has a question. I'm going to unmute Gopi. He's joining in from Hyderabad, and let him ask his question on co-payment.
Yeah.
Gopi,
you want to go ahead and ask your question?
Sure. Thank you very much, Professor.
Sure.
Hi, Andrew. So with respect to the setting in which you are explaining the possible zero price effect, I just wanted to know if we could probably extrapolate this kind of effect also in scenarios where there's a fixed out of payment or irrespective of the price of drugs. And would that be a good setting in which we can evaluate the zero price effect for two drugs that are priced differently, but for the consumer or the patient, they have to give a fixed price?
So the fixed price in your mind, is it applies to all drugs?
Yeah, so let me just give you an example. The context is that they have to give $5 and the two drugs in consideration, one may be priced at 50 and the other may be priced at $100. But the quality outcomes are more or less the same based on information available till date.
So they are bioequivalent, you mean these two drugs?
Right, so the market price may be different, but the out-of-pocket price is fixed because of the healthcare plans.
Okay, so you're saying copay is like $5, regardless which one you choose.
Right, for either of the two drugs, it is $5.
Yeah. So I think in this, that would not, if that's a setting, that doesn't really allow us to test the zero price effect. It's not like, you suddenly see people change, facing a different situations, right? They always face this situation. They always pay $5, no matter what drugs they choose. And so if we see a setting like that, even if we get all the data that whatever the insurance company provides us, that would not be a good setting for us to test whether zero price effect presence. And now that might not be exactly the question you ask. You're sort of asking, hey, given what we found, can we say something about that environment when you just charge people a fixed copay, and for whatever drugs they choose, do we expect it has an impact? I would say I'm not sure. I'm not sure how confident I will extrapolate this result to that setting. I think there may be some policy implication we can talk about, which is, should we make the copay to be zero? Okay, then it would literally make the price, the out-of-pocket price to be zero. But then if what you have is out-of-pocket price is zero, no matter what kind of drugs you choose, is it very interesting? I'm not so sure, if you do tell people about the actual prices of the products. My bet is that a lot of people is going to pick the products that is more expensive if the out-of-pocket copayment is the same. And that's just economic theory will tell us. But what you want to do is, sometimes as a government or insurance company, you want to encourage people to choose a product that is lower price, right? Just to reduce the prescription drug cost. And we will be able to say something here that is, you might want to structure the copayment such that the cheapest products, the copayment associated with the cheapest product should be zero. Okay, and then you can trigger people to buy more of that, or to choose. They give an extra incentive, the zero price incentive, to choose that product. Yeah,
I get it. I get it. Thank you very much. It clarifies a lot. The reason I was citing this example was based on an news report last year when Eli Lilly came out with List Pro, which was priced at $50, and which was pretty much similar to Humalog, which was priced at $100. And it was observed that the Humalog prescriptions still maintained their lion's share as compared to the lower priced generic equivalent.
Yeah, I think you do need to, that lower price has to be somehow realized to the consumers. Yeah, otherwise they won't internalize that lower price effect. And if it's you try to use zero price to give them extra cake, I think that could make a difference.
Sure. Thank you very much.
Yep, you're welcome. Yes. Okay, so going back to this slide, and so that's, I already covered that. We're going to be focused on bracket 4 and 5. And we're going to use all the data from Verstappen County. David can correct me if I pronounce it wrong. So I also want to just quickly show you the summary stat. And here is a very basic summary stat that would look at the different bracket. And when you look at this in terms of percentage of choice share, and you look at the first bracket, that is the tier 1 that people have to pay 100% out-of-pocket price. And when you look at all the prescriptions, what you do see is that, let me see here. Actually, this could be useful too. Let me just go over this one too, before I talk about the second one. So this is just showing the share of prescriptions across different brackets. As not surprisingly, the first bracket has the most prescriptions, about 50%, and then the second bracket has about 14 or 15%, and the third bracket we have about 30%, the fourth bracket 5%, but then the fifth bracket also has a significant number. Right? When you add it up, we break into 3 sub-brackets, but when we add it all up, it actually has about 70% of the people who reach the fifth bracket. So when you look at the share in the first tier, that is people have to pay 100% out of pocket, then what we see is 95% of the drug filled with the lowest price product, and people are sensitive to price. So, and when you look across different brackets, as you move from bracket 1 to 2, from 2 to 3, 3 to 4, the difference actually is not significant. When you control for different demographic characteristics, we may occasionally see, when we cross a tier, we see a little bit of effect, but not very big. But when you look at the changes from bracket 4 to 5, when you look across different demographic groups, we actually see a stronger effect. Right? So this is give us some encouraging evidence that we may be able to find something in the regression discontinuity design too. Now, of course, this is not controlling for this is not a regression that allows to control for other things. And so in the regression discontinuity design, we're going to be able to control for demographics, and on top of that, also the forcing variable, accumulated total expenditures. Okay, so again, the idea is to use consumer accumulated expenditures on prescription drugs as the forcing variable, and we're going to be focusing on what happens when it just cross the threshold from the 4th to the 5th bracket, and when people just enter the fifth bracket, then the price of the lowest price product becomes zero price, not just the lowest price. And the accumulated expenditures is going to be the running or forcing variables, and the dependent variable, we're going to be looking at the share of prescriptions that is the lowest products, the lowest price products. And we will have to create intervals too when we compare the shares, and we're going to use a 50 Swedish corner as an interval. Okay, so like I said earlier, we will have a large sample, and the large sample basically includes all the drug choices, and the caveat is that it's potentially subject to state dependence, have a persistence. And so we will also create a new diagnosed samples to address that, to try to alleviate these issues. And so those will be the drug choices that involves new diagnosis. By new diagnosis, what we mean is that we didn't see any purchase that happened in the past 6 months prior to the first choice that we see for that patient. So the size of the drug choice, of course, relative to the whole sample is like 10 times smaller, but it's reduced by 10 times. But still, relative to the lab experiment setting, which they usually may have, even they got 100 subjects is already pretty big. We have 16,000 drug choices. And so this is the equation we try to estimate. We have these accumulated expenditures from the left, cumulative expenditures from the right of the cutoff, and we have these indicator functions that indicate whether you are in the fifth bracket or not, right? So this gamma is going to be the parameter of interest. So once we cross that, we will see whether this gamma is positive or significant, and what the magnitude is. So the result is really quite simple, the analysis here. But we just have a very nice setting that allows us to apply these simple tools, regression discontinuity, to check the result. And so let's look at the results for the large sample. When you look at the large sample, again, the parameter of interest is the gamma. What you see is that we have statistically significant effect, but relatively small, 0.75 percentage point, right? And so what it means is that it only, I don't know whether it's small or big, but if you just take the number literally, it looks like it is small, relatively small. In the linear case, when we basically model the forcing variables as a linear, and to enter the model linearly, is marginally significant, well, actually it's significant, still that's statistically significant, but not very big, right? 0.75 percentage point. But when we look at only new diagnosed patients, you see the effect becomes much stronger. And when you cross the threshold, the effect is 3.25 percentage point. Okay? And it is also statistically significant. And when you look at the effect, when you try to model the forcing variable using a quadratic form, we still see a significant effect. We in fact see a little bit stronger effect. And so visually, we can, pictures is always easier to demonstrate the actual effect. So here you can see that if it's a local linear regressions, and for the large sample, visually, this is the kind of effect we found. This is when we use the local quadratic regressions. And now when we look at the new diagnosis, you can see the effect is much bigger, right? That's true for the quadratic regression as well. So these are really the main results. So I see there's some actions in the chat room. I don't know. I'm happy to take questions if anyone has questions.
So Mayank, can you unmute Abhik and help moderate this question and all other questions at the end?
Avik?
Yeah.
Yeah, you can ask the question.
Yeah.
Yes.
Yeah. Hi, Professor Ching. I have a question. Like, I was thinking, can we actually reverse engineer this ZP effect? So, in a sense, I came across a finding that 1 out of every 5 adults in US, they want to pay $0 for a vaccine, COVID vaccine. So, is it so like for things that are really good for us, like highly beneficial, and the perceived value is very high, we tend to believe that we should get it for free, and like someone like the government should pay on our behalf, or can it be like thought like that?
That's a very interesting question. So you're asking about, you're talking about specifically for vaccine, right?
Yeah, the COVID vaccine
The
specifically.
COVID
Yeah.
vaccines. Yeah. So I think that would be interesting to see what happens there. You know, obviously it's a big conjecture. But if you ask me whether that were the zero price, do we expect that you make a zero price, people we will encourage a lot more people to adopt. I think, you know, we all know that the adoptions of COVID vaccines is going to be a challenge. And maybe not so much in other countries, but in the US, it will be a challenge. Because even flu vaccines has been around for so long that there are a lot of people who choose not to take it. They still don't believe it's safe, and so on and so forth. So I think, you know, in this case, we have a lot of other factors, confounding factors that complicate the situation. And even though zero-price effect is maybe there, in here, you know, it's not going to be state dependence that matters. Here is much more like the risk aversions and uncertainty story, right? You try to pick a new products, a new treatment that, you know, by definition is new. Not a lot of people have tried it. Yes, we have clinical trial, we have a phase 3, but still, you know, relative to entire populations, it's still a small sample. You know, one can argue that way. And you know, do you want to wait and see, even though it's free? And in fact, you know, sometimes when they make it free, people might even, it may cause more suspicions there. So I think, you know, in this particular example that you use as, you know, vaccine, whether people that can encourage more people to use it, I'm not so sure. Yeah, even if we make it zero, in fact, you know, we might actually have to go further. But you know, the more you do it, the more suspicions that people may have. You know, when I just say go further, I give people incentive to do it. Maybe, you know, like you know, CVS Pharmacy is a chain pharmacy in the US. How do they encourage people to take flu shot? They will actually, they pay you to do it.
Exactly, they'll give a prize.
Yeah, they give you, you know, $5 coupon or something like that. So I think, you know, something like that may have to be used. Yeah.
Basically, the externality question is also going to be a confounder here for vaccines. So that needs to be washed out, and then we have to see if we can re-engineer zero price as a policy recommendation. But yeah, okay. Thank you, Andrew. I will have to step out, and I'll let the others continue. Thank you so very much, and sorry about today for stepping out.
No problem, Chirantan. Thanks again for having me.
Thank you. Bye-bye. Stay safe.
Sure.
Bye-bye.
Yeah, thanks, you too. Yeah. Okay. So any other questions? I'm happy, you know, I can talk about some caveats, and that won't take up too much time. I can go over that, and then towards the end we can have some time for discussion. How about that?
Yeah, we can do that. There's no more questions, so we can do that.
Okay, I heard some voice, but I cannot hear very clearly.
Yeah. So it's okay. You can continue.
You can
There's
go
no
ahead,
other questions.
Right? Okay, so I'll go ahead.
Yeah.
Okay. All right. So let's talk about some caveats of this study. So it's a simple study, but I think, you know, it is you know, we always have this question whether lab experiments can be extended to real world setting, right? And so And here's one example, it's a very important example, pharmaceutical products. Prescription drug cost is spending out of control. How can we make it more people to choose generic drugs or choose other products that basically certified to be the same quality, and if it's somehow it's the better price, how can we encourage more people to use it? And so this Swedish government benefit schemes actually provides some extra evidence to support maybe charging people with zero copay instead of positive copay when people choose the lowest price products could be a good policy to implement. Okay, so now, but what about our research study? Going back to our research study, let's try to play the devil advocate against ourselves and think about what may be missing there, right? And what are the confounding factors may explain the result. How about income effect? Okay, fair enough, our regression does not control for income effect. Neither did Japan, neither did other studies in the labs in the previous research literature. Let's dive into it a little bit. Do we think this is a big effect? We were going to argue that may not be, and that goes back to the actual out-of-pocket prices per prescriptions. We are not really talking about a lot of money here. When it comes down to the lowest bracket, the bracket 4 and 5, the mean out-of-pocket price per prescriptions for the lowest price alternative is only Swedish krona 7.64. Right? That's about 90 cents US dollars. And if you look at the closest intervals, right, to the discontinuity cutoff, right, for those products, the lowest price alternative out-of-pocket price is even lower. Now, Swedish economy is that this is a low price, right? I think even for I would say even for vast majority of the U.S. Population, although U.S. inequality is pretty big, Swedish, I think the income inequality is much better shape, and so we really feel that that's played a really minimal role. And plus, this is a 90-day supply, right? So just reiterate the point that I made earlier. When you convert it to daily cost, we're talking about like less than a cent per day, right? So when you think in this way, it's really kind of like close to epsilon of zero price, even you are in the bracket 4, right? So once you move from bracket 4 to something you're paying very, very little already, when you pay zero price, we see among the 5% of people who didn't choose the cheapest products, now when they're able to save just like 1 cent a day, less than a cent a day, and they still like more than half of those people pick the lowest price product. Right? I think that's how you see how strong the effect is. Now, price placebo effect, and I think we already come across that discussions. With the price signal quality. So the lowest price products would people actually be more skeptical about the quality. And now if that's the case, then actually what it will strengthen the effect, right? Because what we expect is that when the price becomes zero, people, if they doubt the quality, then they will they have an incentive not to choose it. And yet we see positive zero price effect. So if this quality things, price as a signal of quality is there, this story, then it would imply that the zero price effect, the kappa effect, should even be stronger. Now, that being said, we don't feel that it is particularly important, precisely because the price, it's the out-of-pocket price. The consumers know that. And that's not the true retail price. Now, one can still say, hey, but every month these companies beat, right? They submit a bid and they lower the price to become the good of the month. And maybe they compromise the quality if they becomes the good of the month, that particular month. But again, they're not always the same products becomes the good of the month, right? And even if it is the same product becomes always the good of the month, these are the consumers, previously they choose something else. And then once they cross the threshold, now they move to the lowest price products. Right? So I think, still, if anything, is actually strengthen our conclusions. Now here's the catch. Here's the real catch. Close to the boundary, and let's bring this up front, right? Even if the product is not zero price, 95% of the consumers, close to 95% of the consumers, already choosing the lowest price product, right? So the lowest price already is pretty effective, right? And now, hey, we get an extra 3 percentage points of people. So we increase people from 95% to 98% when we have this zero price effect there. I would say it's still pretty good. And an extra 3% of people choose the lowest price products. Now the fact that there is no room for, one may say that, hey, there's very little room for us to see the effect. And I would actually say that, well, what you should be focusing on is the amount of set of people who didn't choose the lowest price product. Now, when they see zero price, how many of them now choose the lowest price products, right? That should be the way to see how big the effect is. Now I do want to say that I think we do admit that like all regression discontinuity design, we still have a word of caution for everyone, because only the people who make it to the 5th bracket that we can use them to test this hypothesis, right? So in some sense, it is still a selected sample. But just like any regression discontinuity design, that's always the case. Only people that we observe in the neighborhood of that cutoff can be used as a sample for the testing. So we are not alone, but when you look at the percentage of people who make it to the 5th bracket, right? When you look at the summary statistics that I showed you earlier, that's about 60 to 70% of them, and so that's still quite a lot of people. And is there any reasons for us to believe that maybe people who are in the earlier bracket, they will behave differently? Well, strictly speaking, we don't know, but it is still, I think, pretty interesting evidence. And if you look at the lab setting, they also have selected samples, right? Champagne, Early, and Mazer, and their selected sample is the MIT students. So I think in this sense, I think we provide another set of evidence. But of course, do we want to extrapolate the result to the whole populations of Sweden? We do need to be cautious about that. Yeah, if anybody in Sweden is listening, any administrators, policymakers, I hope they will think could be a good idea, and may try to give it a try in some pilot setting. And to conclude, again, I want to highlight this is the first study that uses quasi-experimental settings and field data to test the zero-price effect. It is a market that is important. I mean, of course, chocolate is important too, right? But I think drugs are more important than chocolate. Drugs can save somebody's lives or relieve symptoms, and it's interesting, that because somebody may think that, hey, this is a relatively utilitarian products, we might not expect to see a very, very strong positive zero price effect, but we still found it. Now, if you say, increasing from 95 to 98, I think we can argue about that. It's a big effect. But more academically, we're interested in detecting whether the zero price effect is there, right? So it happens. This is a really nice setting that for us to look at in the real world environments whether people are motivated by the zero price, and we found it. So that's I think that's the part that I think it is interesting and exciting, because yeah, I mean, a priori we don't know what to expect, and so in terms of policy implications, talk about that a little bit, and David and I will be very happy to hear more inputs from you if you have more suggestions. I know in the audience a lot of people interested in policies, and we would love to hear your feedback. If you have suggestions, we will be very, very open to listen to it. Okay, so that's all. I finished the talk early, and I'm actually I don't know what time I'm supposed to end.
Thanks, Andrew. Yeah, it's around 1 hour, so that's the time. So I have one question for you.
Yes.
So in the earlier plots of this regression discontinuity, there is a near the threshold there is a negative slope curve. So just before the threshold, the people which have out of expenditure, yeah, this one, figure 4, even figure 3 and figure 4, yeah. So why? What's the reason of this negative slope just around the cutoff? So are people when their out-of-pocket expense reaches 5,400, they start purchasing more costlier drugs? So what's kind of going on here? Why do you think the negative slope?
Yeah, that's an interesting observation. And so in terms of the slope, visually we can see that, and I'm trying to see in terms of the actual results. And the slope is basically represented by the beta.
Beta 1L, yeah.
Beta 1 and beta 1L, beta 1R. And strictly speaking, when you look at them, they are actually not significant. And so, but we plot them anyway. We use the point estimate to plot them anyway. So, we can talk about conjectures, but do we want to take the slope really so literally? I'm not so sure. And David, what do you have some thoughts on why it could be negative? Why it could be trending negatively?
No, not really.
Yeah. Yeah, when people spend more than they, it's not, it's a good observations. And
maybe
if I try to come up with something, it's just conjecture. If we come up with something, it's just conjecture at this point.
I was thinking maybe people are aware of this 5,400 cutoff, so they try to reach that goal. So around that goal, their behavior kind of changes.
Oh, that's another good one. And we actually have another discussion on that. So you kind of maybe alluding to the idea of when people behave strategically.
Yeah, strategic behavior.
And now somebody may think, okay, well, I may try to stockpile and get to the cutoff earlier so that I can pay zero price. And would that be applicable here? And I think the answer, when we thought about it, our answer is unlikely. That's because this is, you will be thinking about the whole year. And this is cumulative expenditures. So I'm trying to reconstruct the argument that we had before.
May one thing to think about is that this accumulated out-of-pocket cost is only cost for the cheapest alternative that is included in this accumulation. So if you buy the more expensive drug instead, that do not affect where you are relative to this cutoff. So you cannot reach this zero price bracket earlier by choosing more expensive drugs, because it's just the cost of the cheapest that is included in the insurance.
Yes, yes, thank you, David. Yes, yes. Does it answer your question?
Yeah, it kind of rule out the strategic behavior, but yeah.
Yeah, so it really, yes, yeah. So it's not like the true out-of-pocket expenses that matter. It's actually the out-of-pocket expense for the cheapest. They only count the expenditure on the cheapest products. That part towards the cumulative out-of-pocket expenses.
5,400 cutoff.
Yeah. So even you pay okay, I'll buy the most expensive one. You pay the price difference. So that price difference does not enter this cumulative out-of-pocket cost.
Okay.
Okay.
Thanks.
Yeah, that's a good yeah, a good guess about what might be happening.
So Gopi, do you have a question?
No question, Mayank. I do not have a question. Thank you. Thank you very much.
So thanks, Andrew. I think no one has a question now. So it's a nice presentation, nice idea.
Thank you.
Implementation. Thanks a lot for the presentation. Thanks.
You're very welcome. Yeah, thank you. Thank you very much for having me. And yeah, so it's great that great to have this opportunity to present, and that's about time for us to hopefully wrap up this project.
Best of
Yeah,
luck.
so later, anyone has more feedback and suggestions, please feel free to contact either me or David, and we will be and maybe just contact both of us at the same time, and David Sunstrong, and the paper that I think is available online. I sent the draft to the organizers, and so there you can find our email addresses, and we'll definitely welcome suggestions and comments. Thank you.
Thanks a lot.
Thank you.
Thanks, Andrew. Thanks, David. So, yeah.
Thank you, Professor Ching.
Thank you, Minnie. Yeah.
Thank you.
Great.
Please take good care.
Thank
Stay
you. Thank
safe.
you.
Thank you so much. Thank you all
Yeah.
the participants for attending. Thank you. Bye.